Excellent presentation by Dr. Smith. The problem is that I think urologists are getting the short end of the stick with this whole coding business because the best codes are the ones that interventional radiologists have, and ours frankly suck. The one that they use for that one for ultrasound needle guidance have dropped like something like 80% in the last 3 years. Anyway, so first and foremost, I could not be here without the effort of all the team that's been involved in our program since 2013, all over these years, and especially the physicians who have believed in this methodology and are reproducing these procedures in their own offices. A lot of this came after 2012, of course, the screening and the most recent update of the guidelines, where harm was greater than benefit, and therefore the recommendations against screening prostate cancer. We've been aiming at that question with the intent to decrease harm, and I think that's the role of focal therapy in it, because the data is starting to show that there's a decrease in and basically organ-confined prostate cancers and an increase in the rate of metastatic disease discovered at diagnosis, and this is obviously an undoing of all the good work that PSA really brought to our field during the 90s and 2000s, and it may have been, we led to over-detection and over-treatment, but I think focal therapy in general will tackle that problem. Anyway, just to go fast into these things, the emphasis of our program is quality of life to avoid harm and local cancer control. And for that, when we wrote the protocol, we wanted ample eligibility on it. We wanted events. So starts at 55 to 65 years old. If the tumor burden is less than half of a gland, on a Gleason 6, they're eligible. If they're Gleason 7, anyway, 3 plus 4 or 4 plus 3, so far that is less than half of a lobe, then they're eligible. And if they're 70 or older, as long as less than half of the gland, all comers are welcome. The follow-up, PSA, IPSS, Euroflow, PVR at 3 months, and then we check the PSA every 3 months during the first year. MRI were mandatory up to about 6 months ago. MRIs are mandatory at a year, and a biopsy was mandatory up to about 6 months ago. And then the outcomes that we look are, of course, conversion to androgen deprivation therapy or to radical prostatectomy, radiation, metastases, and overall survival at the end. So like we discussed yesterday, pretty much as a urologist, all this takes a lot of time, and as you can see, there's not a whole lot of reward around it, so we outsource a lot of this in order to expedite and be efficient in the process of doing the fusion. Our planning is done, and then we go ahead and focus on executing, using a local technique that I basically devised in 2014. Okay, and here's an example of how we monitor as we're doing the cryoablation. This is a typical plan. We have the lesions, we have the areas that we want to cover, and we show this sometimes to patients before so they understand what's going to be done and what's going to be expected. All the information is digitalized into an app that patients have accessibility, as well as their physicians and their centers. And of course, the goal is to destroy the lesion, monitor, and be sure that you accomplish what you intended to accomplish. This is the evolution of the program. And last year, we did about 215 procedures across 3 cities, and it's basically growing. So far, we've done 791 procedures in 683 patients by the end of last year. This shows this was showing kind of like how it's not working. Anyway, the periprostatic block work. The first assessment that we did after we came out with a protocol to block the perineum was evaluation using the FACES scale of 101 procedures done between 2014 and 2015. And we noticed that most of the pain was really associated with the Foley insertion, with the transrectal probe insertion, and then the start of the periprostatic block. Indeed, our first 20 cryoablations were done on propofol in the office. And one of the things that I realized promptly was that when patients were waking up from propofol and moving, it was just the wake up phenomenon. They were not really having any pain as the freezing and thawing process was occurring. So that led us to really focus on blocking this in the beginning, as later on they're just taking a nap or chatting with you, etc. This video I kind of showed yesterday how we currently are doing this. we modeled, and we do what's called a passive stepper fusion, and then we go ahead and do the actual procedure. But it's all based on the fact that all the information has been pre-planned, is loaded into the system, and really what the urologists have to do is just a nice swap of the prostate. They determine where are the points of the prostate that is going to be compatible with the MR, and then the biomechanical model will bring you the fusion of both. And after that, we have the actual targets in place, and we can go ahead and execute the treatment. And that's what this is going to show in a few seconds. And then we put the needles, and then it's just about monitoring. This can be, like we said, done in the office. Eventually, you can train your nurses or your PAs to help you monitor this patient. And one of the beauties about this in the office is that you can actually maximize your productivity because after you finish your first freezing cycle, really, you know what's going to be the extent, and you know there's any chance of harm or not. And if it's safe, you can go and start seeing your patients when the procedure gets concluded somehow or some way, like it's done when we do ESWLs, with the difference that you don't need a patient under anesthesia in the hospital. You just do it in the clinic. And those of you who have been in Miami have seen it in real time, and those of you who have not are cordially invited to come any given time, as we're doing this every week and pretty much every day of the week. So here is how the needle goes into the actual prostate, like we showed yesterday, and after that, the freezing and thawing process goes. And I like to, once we hit the target as we go, it's really a beauty, and it works pretty nicely. So just continuing with all the information gets digitalized, so we can have all the data available. So this analysis is about 525 patients done with office-based procedures, 50 to 75 minutes in length, and about 8% of them experienced an adverse event based on the CTC grading, but most of them were grade 1, and we only had really very few grade 3 events. Between August of 13 and 19, 654 patients, and out of those, 622 were initial and 30 were salvage procedures. 80% of them were really focal. The rest were either hemiablations or whole gland ablations. And this kind of shows the histogram plots, basically revealing the data on the PSAs. The median PSA for our patients around 7. Clinical age, the median age has been 71. And it shows the gland sizes as well as the PSA densities. When we look into the volume of the lesions, most of the lesions are pretty much under 2 cc's, and the dominant lesion sizes are shown in the graphs. This one here shows the total positive cores and the total number of cores and the positive cancer biopsy percent, and most of them are between 25 and 30%. Table here shows the Gleason grade groups and how they distribute in terms of PSA as well. So 81% of our patients with PSA less than 10, 77% T1Cs. And we have a nice distribution in terms of the PIRATs of the MR before, 27, 38, and 31% for 3, 4, and 5 respectively. As you can see, 60% of our patients had a single area covering what we call a single lesion. That may mean a couple of tumors that are very close to each other, and 38% require at least 2 separate segments in the prostate. Okay, this shows the pain distribution. Most of them, the median pain score is between 1 and 2, really, and the median times of treatment. Here's the follow-up status, and basically this, what we try to show here is that the maximum available follow-up, if we take everybody, will be 28 months. We're at a mean about 20 months, so we only have like an 8 months discrepancy. And that's one of the things that where the app really help us to be proactive. We have to be proactive in following it up in all these patients. Median drops in PSA, roughly 75%. You can see the interquartile ranges between 83 and 63. It's very consistent. As we go, we have done now 230 biopsies. We did out of 298 patients that had 1 year information. And in those men that were able to do the biopsy, 37% of them were positive. I don't have the breakdown between infield and outfield. We'll give you that in a year. 201 of those 230 biopsies were MRI transperineal fusion biopsies, okay? This shows the freedom from radical prostatectomy on the right panel and the freedom from radiation therapy on the left panel. All the plots and projections estimates for the 5 years. So you can see the conversion rates are very small. We had, out of those 683 patients, only 17 of them who had a radical prostatectomy and roughly 20 radiation therapy. Again, 37% positive when we ask the question, what predicts a positive biopsy? So far in our data, neither the Gleason, neither the PSA, neither the clinical stage, neither the PIRATs of the initial MR predicts. We looked at age, and you can see the distribution. You see the PSA in between positive and negatives. It's very close to each other. PSA density has not panned out, at least in our cohort. Looking into a continuous variable, clinical stage, and what is kind of tending is how was your biopsy done before, whether they had a transrectal versus transperineally. And so far, the difference is not statistically significant. However, it's about a 12% clinical difference. So we encourage the use of transperineal biopsies before we actually do the treatment. This is a paper that we're going to present at the AUA this year, and it basically shows the role of the MR if we were to apply the PIRAT system to the MR at a year, and the correlation that it has with a positive biopsy. This is data that really was analyzed by September last year, and since we altered our protocol, so if an MRI is a PIRATS 1 or 2, on the follow-up, we're not doing the mandatory biopsy anymore. The patient has the option, and then they get follow-up over time, and between, based on their PSA dynamics, a biopsy will be done, or another MR. But if they're a PIRAT 3, 4, or 5, then we recommend a biopsy in all these patients. From a functional outcome status, 74% had improvement in mean flow rates, and the IPSS have dropped from 11 to 5 with a maximal flow improvement rates of 7 cc per second. By 3 months, 78% had erections and 70% had ejaculation, and I will argue that this is one of the outcomes that we underlook the most, but at least men in Miami like a lot. By 6 months, 86 and 75% respectively for those two. This is the typical changes in flows that these patients have, which I think opens door for cryoablation for BPH. And also, well, these are some of the things that have allowed us to get here. So MRI that request standards, we work with the radiology institutions to make sure that the protocols and the image acquisition is as good as possible. We outsource. Some institutions don't allow direct downloading, so you have to get always the CD from patients. And the key is really to standardize as much as we can. The limitations, well, these are just preliminary results. 5 years is really nothing in terms of treatments for prostate cancer. We're going against treatments that have been there for 100 years, just like surgery. But a single center, it's made the bulk. Now we have 2 other centers that are really growing at a nice rate. And will serve as comparison to other ablation techniques. And patients are closely surveilled with the app. So in conclusion, I think that office-based MRI fusion is very promising. There is really no harm to it, or minimal harm. Patients are awake during the procedure. They will have an improvement in urinary function, and there is a preservation of the prostate function as there is ejaculation. And oncological control is looking very promising. One of the things I didn't mention here, we have about an 18% retreatment rate out of those patients who have a positive biopsy. So there's a significant decrease in cancer burden that you can treat it the same way. So thank you very much for your attention.